Let me get my little camera together here. Hello, everyone. Good night. I'm coming on as promised to talk a little bit about HPI, History of Presenting Illness, and how that relates to pertinent positive and pertinent negatives. So the HPI is basically just a story, but it tells the readers a lot of information about what the patient initially came into the hospital complaining of and what we ruled it to be in or out, basically. So it builds your assessment later on in your assessment and plan. It's not really easy to do unless you are very clear on your symptomatology. So if you know that a patient is coming in with chest pain, then you have to know those things that you have to look for with chest pain, such as pulmonary embolism, pneumonia, heart attack, costochondritis, trauma. So those are all things that you will ask the patient in pertinent positive and negatives. Now let me back up a little bit. So when somebody comes into the hospital, the history of presenting illness will tell you basically what the patient said, and you have to build on that, and it's called old cart. Onset, location, duration, characteristics, aggravating factors, therapeutic factors, and prior treatment. So the way to do that is if somebody came in, I'm going to use chest pain because it's one of your easier ones to do, and said, hey, I have chest pain. Then you may say, this is a 45-year-old African-American male with a history of onset, 3-day acute onset chest pain, left-sided chest pain, radiating. Is it moving anywhere? Can I reproduce that chest pain? What aggravates that chest pain? What makes it better? Any symptoms that went along with the chest pain, such as nausea, vomiting, radiating to the back of the arms, diaphoresis, was the patient sweating with this? All this builds a case. And then you start asking your pertinent positives and negatives to the patient. So, did you have sweating with it? Did you have nausea? Were you on any long travels? So you're trying to rule out whether or not the patient has a PE or has a risk for PE. Do you have any leg swelling with it? Have you ever had these symptoms before? So all of that is important. And when you think about pertinent positives, what is pertinent to this diagnosis that I cannot miss? And what is not so pertinent in terms of negative? So if you're saying the patient has chest pain, does the patient have pneumonia? Then your pertinent positives will be fever. That would be a pertinent positive to pneumonia. So it'll either rule it in or out as a potential diagnosis for the patient. So if the patient didn't have fever, what about cough? So if somebody comes in with chest pain, you may want to ask about that as well. No cough. Any prior sick contacts? That will tell you whether or not this could possibly be some type of contagious pneumonia. If you ask the patient, have you had trauma? Then you're looking at motor vehicle accidents, whether or not you have punched in the chest, whether you fell in your chest and you could have a broken rib. So if you say, were you sweating, nauseated, stomach pain, back pain, then you're ruling in the possibility of an MI. Of course, you're going to get other pertinent factors, but these are all things that would determine, especially when consults start looking at your chart, whether or not these patients have these symptoms on admit, and does it rule this in or that in. Now remember that if you are the consult in this case, especially as a nurse practitioner, you're going to look at all that information and it's going to matter to you. But what you want to do is always go back and do your own interview. Patients come in one way, they're very hyper, they're scared. So sometimes they leave things out of the initial interview in the emergency room, and sometimes they change their story a little bit when they start thinking of things. So it's very important to do your own interview. I can't tell you how many times a patient has came in and the physician felt like it could be non-STEMI, or it could be patient had a lesion somewhere where they need to be ruled out for a potential heart attack later, and it was a PE. Because I'll never forget one time I had a patient, we done all the workup. We did a stress test on the patient. We did troponins on the patient. We did BNP on the patient. And then but I never interviewed the patient. I got this patient from overnight when I came in the morning. And so when I asked the patient the next morning, I said, well, the night shift did all your workup. It looked pretty good. We're going to discharge you. And he said, well, what do I do the next time I get this pain in my chest and I get short of breath when I'm working? And I said, well, what kind of work do you do? And he said, well, I drive tractor trailers all day. So I'm sitting on the field. It was like cutting grass with a tractor trailer or something. And I said, oh, well, this guy is at risk for PE. So we sent the guy for a CTA of the chest, and sure enough, he had a PE, but we were almost about to discharge his patient based off all somebody else's interview and assessment and plan. So make sure that if you are picking up a patient from ED or from a nocturnist at night, that you do your own interview on that patient and you document those things that are relevant to your assessment and your interview. That interview is your HPI. What the patient came in with complaint of, and then do your old cart: onset, location, duration, characteristics, aggravating factors, relieving factors, prior treatment. You always want to do your own assessment and then build your pertinent positive and negatives based upon the person's complaint. So if the person came in with chest pain, rule out anything that chest pain could have a diagnosis of chest pain in it. If the patient came in with abdominal pain, that's a big, broad topic. You have to rule out a bunch of stuff. You have to rule out MI. You have to rule out any abdominal abnormalities such as cholecystitis, appendicitis. Then you have to go further. You have to still rule out sepsis. You have to rule out acute kidney injury. So there's a lot that comes with a belly complaint. You have to rule out UTI, but just make sure that you know what potential diagnosis can be caused by what symptomatology, and that will lead your pertinent positive and negatives, and that will help you build a very strong HPI, pertinent positive and negatives assessment and plan. You do not want to look like you have no idea of what you're talking about in a note. If you don't know it, look it up. Consult with a colleague. That is not uncommon to do. When you pass boards, you have to know the bare minimum, and then you have to continue to build on that every day as a provider. So make sure that you build a strong HPI: onset, location, duration, characteristics, aggravating factors, relieving factors, prior treatment, and then build your pertinent positive and negatives based upon what the patient's complaint is. Know your symptomatology. All right, I hope that helps somebody. Anybody have any questions? All right, well, y'all have a good night. Thank you for your time.